All right, so we are going to be starting this webinar. We are live on YouTube. So, good evening, everyone, and I welcome you all to the free webinar on Let's Unleash the Fact, New Treatment on the Horizon for Rectal Cancer, which is organized by the International Association of Oncology, IAO, and by scientific partner BioLeaks Worldwide. I would like to talk about the scientific partner. As a non-profit, BioLeaks Worldwide is a globally recognized professional association that operates under the Technorite Group. It serves to propel and fuel all innovative works of research with immense potential in the fields of healthcare, life sciences, pharmaceutical sciences, and the medical sciences in general. In this capacity, BioLeaks Worldwide has been directly responsible for a significant amount of the revolutionary developments that have taken place in these fields over the past few decades. Now, to talk about our organizers, the International Association of Oncology is one of the world's leading professional associations for medical oncology and life sciences professionals caring for people. IAO is a non-profitable professional association meant for research and development in the field of medical oncology and life science. IAO is an international forum for researchers, academicians, doctors, and practitioners for sharing knowledge and innovation in the field of healthcare and life sciences. IAO aims to bring together worldwide researchers and professionals, encourage intellectual development, and providing opportunities for networking and collaboration. IAO delivers access to its members the industry's most essential technical information by organizing conferences, workshops, annual convention meeting, and provides networking opportunities both locally and globally. Members have the ability to stay current in their chosen profession, connect with peers, and invest in their future. IAO provides a broad-based home for members and societies who are interested in aspects of the medical oncology and life sciences together with companies, hospitals, government organizations, pharmaceutical company researchers, and university researchers. On that note, I would like to welcome the dignitaries of the event. I would like to welcome our IAO President, Dr. Gyanasham Biswas. He is currently working as the Executive Director, Sparsh Hospital and Critical Care, Bhubaneswar, India. I would like to invite our other panelist, Dr. Birendranath Banerjee. He is the founder and MD of InDNA Life Science Private Limited, Bhubaneswar, India. I would also like to invite Dr. Subhashish Mohanty, currently working as a consultant hospital pathologist at some Ultimate Medicare, Bhubaneswar, India. I would like to invite Dr. Anantakumar Agasti, currently working as consultant gastroenterologist, Kalinga Hospital, Bhubaneswar, India. Next, I would like to welcome Dr. Soran Das. He is currently working as the head of clinical research, KIMS, Bhubaneswar, India. Next, I would like to welcome Dr. M.V. Chandrakant, currently working as consultant medical oncology, Narayana Super Speciality Hospital, West Bengal, India. I would like to welcome Dr. Sanjeev Mishra, currently working as consultant radiant oncologist, Sanjivani Hospital, Bhubaneswar, India. I would like to welcome Dr. Dilip Kar, currently working as surgical oncologist at the Kalinga Hospital, Bhubaneswar, India. I'd like to welcome all of you to this wonderful webinar, and I'm sure the discussion ahead is going to be filled with lots of ideas and innovation. Now, I'm going to hand over the webinar to Dr. Gyanasham Biswas to start today's panel discussion. Dr. Biswas, the floor is all yours.
Yeah, thank you, Fatima, and so welcome. So where is the slide?
Sir, your screen sharing is on and we can see your screen. Please proceed.
ବେଶୀ ହବନି ସେ ମେଲ ଏଇଟା ତ ଠିକ ଅଛି ନା ନା ମେଲ କୁ ପଠେଇବାକୁ ପଡିବ
Mr. Ananta Agasti, Dr. Ananta Agasti, can you please go on mute, sir?
yes hello
Sir, can you please go on mute?
yeah
Thank you. Dr. Bishwas, are you there?
Is there certain?
1 minute, sir. I am sharing, sir.
Yeah. So could you? Can you see the slides?
No, sir, it's not visible.
no not visible
So now,
Yes, it is visible now.
sorry. So there is a goof of. Absolutely. So thank you, Fatima, and so sorry for the delay. So today, so there is last few days, so there is so much of buzz and news about the new drug. So dostarlimab, Jemperli from GSK. So that's why I chose that. Let's unleash the fact. So new treatment on the horizon for rectal cancer. So today we have the city's best molecular, the pathologist, the medical gastro, the radiation oncologist, surgeons, and so I chose a research person so who have been instrumental in setting my research unit, and from Kolkata, Dr. M.B. Chandrakant. So this ASCO 2022, we just concluded on 7th of June at Chicago. And if you see the trending, so there is a news about Mahima Chaudhary's breast cancer, then Mithali Raj quitting, COVID fourth wave, but the major chunk has been to dostarlimab, that's Jemperli. So lots of tweet. So you can see one of the tweet, a retweet to Dr. Pramesh. So too much hype too soon. And you can see all those electronic news of 6 महीने के दवाई से कैंसर पूरी तरह क्या खत्म. So cancer cure. So what is the historic drug? Dostarlimab. So miracle, a drug trial erases cancer from every patient's body. And there are many tweets. So one of them from Dr. Patil. So now since normal individuals or cancer patients who probably have an MSA high, so you get a call or a WhatsApp. So is that drug applicable for me? So coming to the cancer burden, so from 2002 now 2020. So while these years, you can see the prevalence has moved from 25 to 50 million, incidence from 10 to 20 million, and cancer, in spite of all those research happening, so still 10 million people are dying from cancer. So in short, cancer incidence continues to rise from the Globocan. Now you can see, so the Globocan 2020 on the left-hand side, new cancer cases. So colorectal is one of those 5. If we talk about the deaths in the global, so colorectal cancer again is number 1 in the 5. If you talk about India, in males, definitely colorectal is among those new cases, 5 common, and in also death, but is not so common in regards to incidence or deaths in a female. So we'll start our talk or the discussion with Dr. Biren. So the medical progress has been from superstitions to symptoms to signatures. So that's the era of precision medicine has begun. So because all cancers are personal. So we have moved yesterday from symptom-based to today pattern-based, and today we are talking about algorithm-based, so precision medicine. Because so dostarlimab, we are talking is a monoclonal antibody or immunotherapeutic agent. So that's why we are into a precision era. So Dr. Biren, so what is precision medicine today in short?
Yeah, thank you, IAO, and thank you, Dr. Biswas, for having us on this panel this evening. Yes, we all are getting this news feed. So precision medicine is the buzzword today, and precision medicine is called a medicine with a target. So today it has been more or less established that cancer is a gene-based disorder. It's a disorder of the genes or dysfunction of your genes, and therefore, if we find the target, we have the bullets which can reach the targets. And the news today we have is one of these monoclonal antibodies, which is a checkpoint inhibitor, which is targeting the PD, that is the programmed death signals in the cancer. So this is the era of targeted medicine, where we have the precision, where we will see the target and then assess the target and then devise the medicine. So it is personalized, it is precise, and it is to each patient is tailored for the therapy.
Thank you, Dr. M.B. Chandrakant. So you are a busy practitioner, medical oncologist in Kolkata. So if you see this note from a Nobel laureate, so one of the major advances we have had is a deep recognition of the cancer. That cancer is not a single disease. So if you look at the cancer, so you look at a genetic level, so it is so heterogeneous. So how it is important for a colorectal cancer? MB, Dr. M.B. Chandrakant. Is Dr. Chandrakant there?
Yes, sir. Yes, sir. Sir.
Yeah. So how important is precision medicine in a colorectal cancer?
So this is extremely important. Heterogeneous disease. Molecular classification of colorectal cancer. We have right and left colon, and then we have KRAS, NRAS, BRAF, MSI day-to-day. You also have tumor mutation burden. You have HER2 new. These are the mutations that we look into. So extremely important. We must do all these biomarkers for a colorectal cancer before we embark onto treatment.
Right. So you spoke about left and right. So today we know that so left and right tumors are different. So once you have a metastatic colorectal cancer, so you need to have understand the patient characteristic, the tumor characteristic, and what is more important is a molecular characteristic. So we need to do all RAS, BRAF, MSI, and HER2. And today's buzzword is MSI. So we'll come to that later on. So before that, let's come to understand the basics. So I bring it here, Dr. Agasti, who is a renowned city's one of the best gastro medicine. So Dr. Agasti, so how common is a colorectal cancer and per se rectal cancer, and how they present to you, and how do you evaluate these patients? So Dr. Agasti.
Yes, thank you, sir, and good evening to everybody. Basically, colonic cancer is the one of not it is the leading cancer of the body, but still it is a most common cancer, one of the common cancer of the body, which is a gastrointestinal. And if you divide right colon, left colon, vis-a-vis rectal cancer and other part of colonic cancer, rectal cancer is somehow more common in our belt, especially in Eastern India, as compared to right side cancer, like ascending colon or transverse colon cancer. So mostly when you diagnose this case or when you suspect this case, because if the rectal cancer patient have a clear-cut symptoms like poor rectal bleeding, sometimes also they present with obstruction, colonic obstruction. At that time, it can be diagnosed definitely by, if it is on the reach of the finger, that means sometimes it's 5 centimeter, 10 centimeter. You can diagnose by peer examination, and for a colonoscopy, you can or a sigmoidoscopy, you take a biopsy. But when you go for a right colon cancer, that means sometimes presentation is some vague. In fact, patient may present with anemia, sometimes pain abdomen, and sometimes intestinal obstruction, sometimes weight loss, fatigue, and a lot of anemic symptoms. At that time, just do a colonoscopy and diagnose the case. So, so far, it is not very uncommon as believed earlier. And nowadays, we're seeing more of a left colon cancer in our belt as compared to right colon cancer. And diagnosis, as you know, it is really not very complex. You can diagnose easily nowadays if you're staying at the city like Bhubaneswar. You can go for a colonoscopy and take a biopsy, and all molecular study, I think it is available in Bhubaneswar. And after that, staging, treatment, everything is a concern of the oncologist.
So thank you, Agasti. So now, another question. So when you are dealing with the patient, so you have planned your investigations on the history taking. So do you suspect any patient that this patient probably fits into a Lynch syndrome?
Right, definitely. There is lots of criteria to diagnose Lynch. Lynch syndrome means what is Lynch syndrome? Just for the audience sake, I am telling. It is called hereditary non-polyposis colonic cancer. That means normally, in fact, the most common things what happens to a colonic cancer, it is a adenoma carcinoma sequence. And patient developed a polyp with a adenomatous character. And this polyp on the later date, sometimes some 10 years, 15 years, it can convert to malignancy. This is the most common sequence which happen in the environmental type of cancer, and genetic marker is always there. But when we don't get this type of sequence, that means there is no polyp, patient directly developed cancer, and there is lots of criteria, including, it is there some Amsterdam criteria, some Bethesda criteria, all these criteria. So just to suspect this type of Lynch syndrome or non-polyposis colonic cancer, there are two to three things which in clinical practice we usually suspect. When patient have a family history, that means if you have a colonic cancer of 2 generations, that means generation 1 and generation 2, sometimes 3 relatives, and one of those first degree relatives having colonic cancer or extra colonic cancer like uterine or breast cancer. That also extra colonic cancer also takes into account. Number 2 and number 3, if colonic cancer diagnosed in a case of less than 50 years of age in a family or having a first degree relatives or second degree relatives. These are 3. Or any colonic cancer death in a family. These 3-4 things, if patient gives the history, at that time we suspect Lynch syndrome or hereditary non-polyposis colonic cancer, and which can be confirmed by doing some molecular study. That means this mismatch correct MLH.
We'll come to that.
Yeah, definitely.
So now the colonoscopy is done, the scans are done, so the staging has been done, and the pathology sample goes to Dr. Subhashish. So Dr. Subhashish, so one of the city's best pathologists. So what do you see? So what are the common types of rectal cancers you encounter? And at times there can be a surprise package too. So once you diagnose.
Sir, most common rectal cancer we encounter is, sir, am I audible?
Absolutely, please go ahead.
The most common rectal cancer we usually encounter is adenocarcinoma. And it is the most, almost 80% of the cancers are adenocarcinoma. Rest uncommon variant like adenoscomas, neuroendocrine, colloid carcinoma, and different variants of adenocarcinoma. But most common is adenocarcinoma.
Right. So Dr. So MB, so now you diagnose a metastatic colorectal cancers. So suppose somebody has come with a MSI high. So money is not a problem. So you'll start with chemotherapy or you'll choose chemotherapy with an immunotherapy.
So sir, MSI high metastatic colon cancer, we have a reasonable good evidence to say that if we can use a monotherapy, pembrolizumab, in comparison to chemotherapy, has better response rates, has better progression-free survival and better overall survival. So definitely in the present era, I would choose pembrolizumab over chemotherapy in a metastatic colorectal cancer. So, however, if you look into the subset of patients with metastatic colorectal cancer, those who have MSI high, and very important is the concomitant mutation. If there is a concomitant BRAF mutation present in around 30% patients, there the benefit with immunotherapy is there, but it comes down. So it is very important whether it is MSI high or it is MSI high along with concomitant mutations. And then even in those patients where there is MSI high, immunotherapy mono, there are some 25-30% patients who have progression as the best response in spite of they having MSI high. So if the disease burden is high, then probably I may combine chemo immuno together.
Absolutely.
Where I cannot afford to.
So MSI high metastatic colorectal cancers, though there are few pivotal trials, one of them is a keynote 177. So what Dr. MB told, so there is a significant PFS benefit, PFS2 benefit. So that's so in a metastatic disease, so this has been absolutely in place. But the news is all about early rectal cancers or a locally advanced rectal cancers. So you can see, so in the armamentarium of colorectal cancers, already immunotherapy is in place. So either single agent pembrolizumab or the combination of nivo and ipilimumab. So now we come to a locally advanced rectal cancers. So Dr. Sanjeev Mishra, so it is one of the city's best radiation oncologists. So how do you plan your treatment?
Usually locally advanced rectal cancer, they are not operable. So usually in a radiological finding, we get a perirectal fat stranding, so that if you are taking a circumferential margin, it will be positive. That's why they avoid to operate. So we give a prior neoadjuvant chemotherapy with radiotherapy. So in such cases, newer techniques are there with a less toxic radiotherapy protocol. We give a long course radiotherapy and sometimes we give a short course radiotherapy. And the long course is around 50 gray in 28 fraction, and a short course you give around 25 gray in 5 fraction. So we give neoadjuvant radiotherapy along with chemotherapy as a radiosensitizer. Maybe usually we use a capecitabine. And after that, we give a month of gap, and then we do plan for surgery. We send it to the surgeon for surgery.
Right. So now that brings us to the oncosurgeon. So Dr. Dilip Kaur is here. So Dr. Dilip, so how rectal cancer is a different way once you are counseling a patient, because you know that colostomy is one thing, so no patient likes it. So how do you deal with the counseling part? So you have seen the patient who is a locally advanced, and right, so you are not going to operate upon at the first go. So Dr. Sanjeev will plan for a CTRT, and then the patient comes to you for a surgery. So how do you counsel your patient, and what are the problems that you can encounter post-surgery? Dr. Dilip Kaur?
If I summarize your question, actually, you are asking for a locally advanced rectal cancer T3, T4 lesion or N1, where Sanjeev is going for either a short course radiotherapy or for 5 days or a neoadjuvant CTRT. In these cases, I think you are pointing towards me for the obstructive symptoms patient is having or not. If the circumference involvement is more than 2/3 and a very bulky disease, and usually the disease is above 5 or above 6 centimeter, and I expect edema or obstructive symptoms during course of radiotherapy, I'll discuss with the radiation oncologist, and then I'll wait. Elective colostomy or elective transverse colostomy, I will not prefer and is not recommended at all. Only if the patient presents with obstructive symptoms during radiotherapy, I can go for a elective transverse colostomy. Is it clear?
Right. So now, so what are the problems you can encounter later on? So 3 months, 6 months down the lane, so your patient comes after a colostomy, no? So what are the problems? What are the peculiarities? So you may not want to see this patient again and again, because they will come with a bowel dysfunction or bladder dysfunction. There will be a sexual dysfunction. So how relevant is this?
See, usually after you mean to toxicities of radiation?
So toxicity of radiation followed by surgery. So both of you can talk. So one, maybe Dr. Sanjeev first, then Dr. Dilip.
It can be divided into the radiation toxicity and surgical toxicity, means surgical symptoms. Let Sanjeev first, and then I'll. Please.
Yeah, the radiation toxicity, usually we get a grade 2 toxicity around 20%, 20-25% of the cases, grade 2 or more. And these are the acute toxicity. So other than that, bowel toxicity very rare. Actually, we see very rarely with this dose what we are giving, around 50 gray or 45 gray. The bowel related other toxicities are less, it's manageable. But when you operate those cases, maybe other complications, other surgical complications usually we come across. I think Dr. Dilip will tell about it.
Yeah, Dr. Dilip.
The question is very clear. The surgical symptoms. If the patient is for the abdominal perineal resection or is it anterior resection. So we are considering for a low anterior resection or anterior resection where Sanjeev and the radiation oncology is giving neoadjuvant CTRT. In these cases, usually we go for a transverse loop colostomy. In these cases, sometimes rarely, we can enter a valvulus, we can enter obstruction because of adhesion, and which is usually self-limiting, there is no need. And only one problem, recently you have seen that if the albumin level is low in your colostomy patients, then they are going to behave badly, which is a recent trial. So my patients, I have to see the nutrition factor in a colostomy and the albumin level. If these two things are jeopardized, then I expect complications of adhesion, otherwise nothing else. No other big complications if you do safely.
Right. So going back to Dr. MB, so which are the patients where you will consider total neoadjuvant therapy? And so do you find this total neoadjuvant therapy in certain patients to be the best?
So, well, sir, I would like to look into the extent of locally advanced disease. If it is, there is extension to neighboring viscera where rectal preservation is difficult, and on giving more neoadjuvant treatment, I can save the rectum. In those set of patients, I would go ahead with the long course RT, and I would like to start neoadjuvant chemotherapy. In fact, FOLFOXIRI or FOLFIRINOX is the regimen in a young fit patient where I would like to give. Again, in the subset of MSI high patients, that is a patient where I would not expect a great response. In those set of patients, I would not go ahead with aggressive chemotherapy because I know I would not benefit. So in a MSI low patient and in a patient where there is an extensive locoregional disease and where I need a proper downstaging, in these set of patients, I would go ahead with a total neoadjuvant therapy with FOLFIRINOX as the backbone.
Right. So now the patient has received a CTRT, or for the patients probably can have completed total neoadjuvant. So how do you assess disease response? So in clinically and imaging wise. So Dr. Dilip followed by Dr. Sanjeev.
It's mute, I think so. Dr. Dilip is mute.
Dr. Dilip or Dr. Sanjeev, you can take.
Yeah.
The most important clinical examination is digital rectal examination. And in the digital rectal examination, above more than 5 centimeters, difficult to assess. Then you can go for a pelvic examination, sometimes under GA, to look for the response. This is some clinical. And if you can add on imaging, then you can go for a MRI pelvis.
So Dr. Sanjeev, so any role of PET CT scan?
Yes, for surgical point of view, ideally it should be MRI actually, because you need to see whether the CRM is clear or not, whether you can take it out or not. But PET CT has got, definitely there is a role of PET CT, because you may not be knowing, you might be getting some sort of metastatic disease somewhere also. So maybe prior to surgery, if you are doing a APR, you have to put a coloscopy. Prior to that, you must know if there is a small liver met there. Then you can address that. Otherwise, you can avoid surgery and go for systemic therapy.
Right. Dr. Agasti, so this patient has post CTRT. 6 weeks later, this patient comes to you for a colonoscopy.
Yes.
So on imaging, so on a colonoscopy, so how do you see the patient doesn't have a good response, or the patient has a good response?
Ghanshyam, can I just have a word?
Dr. Agasti, please.
Yes.
Yes, Anand.
Suppose am I audible?
Yeah, please.
Suppose this patient have undergone treatment in form of CTRT followed by surgery. Suppose you are assessing the patient's symptoms. That is the most important thing. If patient is symptomatic suppose in rectal carcinoma, we are considering patient have any obstructive symptoms, or in distension of abdomen, bleeding, PR, weight loss, or any having problem in defecation. These 5-6 points clinically we assess the patient, and followed by your imaging, what you're telling, PET scan or suppose contrast MRI, all these things that is helping. And ultimately, finally, the protocol is go for a colonoscopy. That is mostly after 3 to 6 months after the complete response of the treatment.
So, Dr. Shubhashish, now the patient has undergone a surgery. Now, so you get the specimen.
We are just with NBI imaging, all these things we can diagnose. Either it is anastomotic stricture, or sometimes some narrowing, or some changes because of surgery, anastomosis related changes in the local site, or any radiation changes. And so
Can I add
go for biopsy? Suppose you are.
Ghanshyam, can I add for a word for a PET CT? Your question?
Please.
See, if you the PET CT you are asking, no, I will. If you go for the ICMR guidelines in our Indian setup, sometimes we slightly. In our setup, PET CT will be expensive for a single hepatic lesion, which is you are suspecting. I'll put my words for a 3-phase CT scan, which is much more economical and which is much more better sensitive than PET CT. That is my take on.
Right. So, Dr. Shubhashish,
Yes.
So now how do you assess? Because the whole buzz about this presentation was that the tumor vanishes. And I think the tumor vanishes only can be told, or we can infer from the pathologist.
Yes. In a surgical resected specimen, we have to find grossly first whether there is any residual viable tumor is there or not. In a post CTRT, usually we find resected specimen with scar tissue only. No, if that is a complete response, we only get a scar tissue. So multiple sections from the scar tissue we will take, and accordingly we score according to the Ryan's scoring system, according to CAP protocol. The Ryan's scoring system tells about the tumor regression grade, that is complete response, near complete response, partial response, and no response. The near complete response means there is no, absolutely from the different sections, there is absolutely no tumor cells, no viable tumor cells under microscopy. Now, near complete response means a single cluster of cell or a few 1 to 2 cells. This is the near complete response. Partial response means that there are tumor cells, but they have gone some CTRT changes.
So the tumor vanishes. That means though there is no single tumor cell, right?
Yes. There is no single tumor cells when there is complete response.
Right, absolutely.
And we have to say that if after CTRT, if we find any mucin legs are there, So if we find the mucin legs without any viable tumor cells, also it is a complete response. And we don't encounter any tumor cells in the lymph nodes. We don't consider it to be metastatic because the main specimen has to be free from the tumor.
So now again, so going back to the molecular person, so the whole buzz is about mismatch deficient rectal cancers. So these are the patients in question in this trial. So what you should know about MSI? So Dr. Biren, so let's the audience know about what is MSI, what is important, how do you do? So what are the frequencies as in crisp?
Okay, so in CRISPS, what I would like to tell is we have in our DNA 3.4 billion bases in one nuclear DNA, but 2% only talks in the form of proteins or RNA. They are called genes. Other than that, 98% of the DNA is present to control these genes. And microsatellites are some of the nucleotide bases which actually are regulatory nucleotides. They are not genes, but if there are some changes or mutation there, then the genes may be affected. Now, we have repair mechanisms in our DNA. Mismatch repair is one of the repair mechanisms. There are base excision repair, nuclear excision repair, but mismatch repair is whenever there is a DNA mismatches between the bases. We have 4 bases, adenine, guanine, cytosine, thymine, ATGC. If there is a mismatch, then the mismatch repair mechanism genes, we have 5 genes, which can first identify the mismatch and then repair it. This is a normal mechanism. So due to microsatellite instability or these nucleotides which are controlling this mismatch repair genes changes, and because of the mutation in these mismatch repair genes and the microsatellite regions which regulates, there is a deficiency in the cells to identify and they proceed. This is one mechanism which the tumor cells hijack in order to grow very fast. So we call it the deficient mismatch repairs. So there are 5 genes. In these 5 genes, there is if there are lack of expressions like in MLH1, MSH2, MSH6, and PMS2 and PMS1. If there is loss of expression that we don't find in proteins, we find it in IHC, that is immunohistochemistry. Or if you isolate the DNA and do PCR or sequencing, we can find that there are mutations in these genes. So this is a very important biomarker to find the tumor, the cause of the tumor, and target these tumors. So this is a classical biomarker. Most of the colorectal cancers and endometrium cancers are written for MSI status, and also the genes which are there in MMR are also hereditary affected in Lynch syndrome. If you have a degree of hereditary trend in your family for stomach and colorectal cancers and other non-colorectal cancers, but the genes involved are the same, we find it that they can be classified as Lynch syndrome. Right. So we have 2 technologies, immunohistochemistry and PCR. More or less, both the techniques are sensitive. One is a protein-based expression studies on the tissue, and another is a DNA-based. If the tissue is less or degraded, we can isolate the DNA and do PCR. But both the techniques are sensitive enough to give us a conclusive report of whether it is MSI high or MSI low or MSI unstable or MSI stable.
So Dr. Subhasis, so would you advocate ISC over PCR or PCR over ISC, or so these can be interchangeable?
Sir, there is the comparison between ISC and the PCR are almost parallel, means these results are quite concordance with the ISC and PCR. Only thing is that the proper tissue preservation is needed for the ISC, where without proper tissue preservation, this immunohistochemistry will not be appropriate for the study. Even a single nuclear expression of this MSI antibodies is considered to be the intact expression. And when we find in an ISC there is loss, means there is no nuclear staining in any proportion of the tumor cells, and then we can suggest that it is a loss. So that's for the tumor preservation and tumor fixation is very important while dealing with the ISC. And the comparison result between ISC and PCR are well in concordance.
Right. So the MSI is usually high in the right-sided colon cancer, and for everybody's understanding, so MSI high is a rare population of patients. So that's why the question in the trial is that we are looking at a very niche population. So MSI high is probably mostly seen in the stage 2, around 20%, stage 3, 10%, and in stage 4, it is less than 5%. So now, so the whole buzz on the editorial NEGM published this week, so improving treatment approaches for rectal cancers. And the same NEGM published on June 5th. So PD-1 blockade in mismatch repair deficient locally advanced rectal cancers. So Dr. MB, so what is immunotherapy, what is monoclonal antibodies, and what are the different immunotherapeutic agents that are available?
So when you come to systemic anti-cancer therapy, we have conventional chemotherapy where it acts on all cells, whether normal cells and cancer cells, and then we have target therapy. Target therapy acts only on cancer cells, and then we have immunotherapy. So if you look into immunotherapy, we have something called monoclonal antibodies. So in monoclonal antibodies, we divide them into chimeric monoclonal antibody, humanized monoclonal antibody, and completely human monoclonal antibody. These monoclonal antibodies can be target therapy and can be immunotherapy. So these immunotherapy molecules have no direct cytotoxic activity, but they indirectly enhance the T cell or the immune cell mediated cancer cell killing. So cancer is a immunosuppressive disease. By expressing PD-L1, it causes T cell energy. So if you can reverse the suppressed immunity by giving immunotherapy, the immune mediated cancer cell killing becomes better. So if you look into dostarlimab, it is a humanized monoclonal antibody against the PD-1. So it basically reverses the immune suppression caused by cancer. So if you have a MSI high tumor, that means there is a defective cell proliferation and there is a higher neoantigen expressed on the cell surface. So these MSI high tumors are extensively sensitive to immune mediated cell killing. Therefore, a bit of immunotherapy push will enhance the immunity to just attract towards these MSI high tumor because they have numerous neoantigens. It is basically a deficient mismatch repair gene deficiency. That means those defective cells which are multiplying, they are defective antigens, and these antigens are neoantigens. The tumor mutation burden in these cells are high. That means they are extensively sensitive to immunotherapy mediated killing, and they are sort of resistant to conventional chemotherapy or radiation therapy. Therefore, it is reasonably a good idea that even in a localized disease, giving immunotherapy looks more meaningful than a conventional chemotherapy or radiation therapy. Or immunotherapy would add benefit to whatever local regional therapies we have. So this is about MSI high, how different it is from other tumors, how it is immune sensitive, and how giving immunotherapy even in local disease can increase local control rates.
Yeah, thanks, MB. So now coming to the study proper, the study salient features were, it is a phase 2 study. The study is small. So till that time, so the press release was there. So out of 18 patients enrolled, only 14 patients have been evaluated, and rest four patients are supposed to be doing good. Single institution, short follow-up of 6.8 months, smaller proportion of rectal cancers. So if you see 10 patients, so probably one will fit into an MSI high, and 6 months of therapy, that is 9 doses of the drug. So cost, you know, the huge cost. Now everybody probably has seen the cost of this drug. So we'll go to the person so who is into research. So Dr. Soren Das. So let the people understand, so what is phase 2 and how it is important, how single institution study should be taken into consideration. Dr. Soren? Dr. Soren, are you there?
Can you unmute?
Hi, good evening, Dr. Biswas, and good evening, everyone. Thanks a lot for this opportunity and excellent discussions going on by the panel of oncologists. Dr. Biswas, can I share my screen just to give you a little about the phases?
Please.
Okay, so just to give you a little insight about the clinical research or the different phases of clinical trials, it basically looks like a funnel with phase 1, phase 2, and phase 3 sequentially happening, where the initial part in oncology is you're taking patients. In this case, let's focus on colorectal cancer. And then you have phase 2, which has a little more number of patients, and then phase 3. And once the phase 3 is done, the regulatory body, whether it's the FDA or the EU or the CDSU in our country, they give what's known as the routine approval for marketing. This is the routine thing that happens for all the trials, whether you're looking at anti-cancer drugs or the monoclonal antibodies or the checkpoint inhibitors that we are discussing now. Now, the other thing that also happens, what you saw was the routine approval, but it also could happen, which has also happened for this particular drug, dostarlimab, is in between the phases of clinical trials, there are chances that the FDA might look at the data and could also approve your trial and the product to get into marketing. And that's also, there are different approaches that the FDA goes through. One, which is known as the fast track approval, or it has what's known as the priority review, or a rolling review, or a breakthrough review, or what has happened with this particular drug, Zemperli, is accelerated approval. So accelerated approval for marketing could happen, especially for diseases which are having unmet medical needs, are serious condition, mostly in cancer or other diseases. They could happen at the end of phase 1 itself, which has happened with this particular drug, because as all of you must be knowing, this drug has already been approved by the EU and the FDA. It's already in the market as a brand name by GSK. It's of course not GSK's molecule at all. And the FDA gave approval on 22nd of April last year, and immediately, and that was for endometrial cancer. And immediately following that, when they started getting more results, they also gave then approval for solid tumors. The trials are going on. However, what happens in accelerated approval for marketing is, this is based on the US FDA guidelines 1992, where they said that they could give approval or an accelerated approval based on good data, high quality data. And 2012, they made this as an act, which was the FDA SIA Safety Innovation Act, where they would look at surrogate endpoints in the clinical trial, or what are known as interim clinical endpoints. And based on that, we have seen in all therapeutic areas, including oncology, of course, oncology has the maximum, there are already 278 drugs which have been approved. And what they mean by surrogate endpoints are, it could be a lab value, it could be an imaging parameter, physical signs, or others, which predict probably a clinical benefit in the long run, or interim clinical endpoints, which would be a measure of therapeutic effect. Again, reasonably likely to predict clinical benefit, like on the IMM, or the irreversible morbidity and mortality, which could happen in any of the diseases. Now, once the accelerated approval for marketing is given at the end of phase 1 or phase 2, the routine development of the drug continues. And you will be surprised, for this particular drug, if you do a clinicaltrials.gov search, there are 42 clinical trials going on for this particular drug in variety of indications. And this particular trial, which is the Garnet trial, you will see, which is a phase 1 trial. Unlike many phase 1 trials which are short, here is what they are known as adaptive clinical trials, where the sample size in a phase 1 is 740 patients, where they have multiple subgroups, where they're doing the subset analysis and coming out with an approval. The FDA clearly mandates that, dear sponsor, you have got the marketing approval. However, you have to continue doing what are known as phase 4 confirmatory trials for all the patients that are being administered this particular drug. At the end of that, it could happen that the drug was approved with an accelerated approval, like this particular drug for endometrial and for solid tumors. But at the end of 1 year, if they do not prove what they had shown as surrogate endpoints or interim clinical endpoints, the drug may not be fully approved and it may be also withdrawn. However, in today's era of monoclonal antibodies and other drugs which are targeting multiple areas, especially in the pathophysiology, the sponsor jumps to another indication. So phase 4 clinical trials may be converted, not converted, or maybe withdrawn for that particular indication. Just to continue before I take more questions, the FDA has clearly mandated what could be the surrogate endpoints or the interim clinical endpoints. For example, in CML, if you're doing a trial for a new drug or a particular monoclonal antibody, it has to be a major hematologic response. For solid tumors, there must be a durable objective ORR or a PFS or DFS. And it's not just in oncology, they have defined it for all therapeutic areas and in fact for all indications. For example, for lung disease, there must be a sputum culture conversion to negative by 6 months. So at the end of 6 months, if you prove that there is a conversion, the drug is approved by what is known as the accelerated approval system. And these are the drugs which have been approved since 1992 till 2021, December data this is, where last year we had around 45 drug approvals based on accelerated, very short duration trials. And there are even trials, for example, I'll give you the name of another drug, which is the Lumosity, which is by AstraZeneca. They had, this is for hairy cell leukemia. They got the approval with just 100 patient data, just 100 patients data. And similarly, on the other hand, the Pfizer drug Visimpro, which is for NSCLC, they had a sample size of 452 patients. And this is the story of Keytruda. If you see how well the sponsor has been looking at this particular product, if you see, April 2014, they started, and immediately within a very short period, they got the approval, accelerated approval again for metastatic melanoma. And right up till November 2020, they have been trying with multiple indications, same drug, multiple indications, and they are getting what's known as accelerated approval. The same is here for this particular, which is made exciting news. One thing I would say, it is an exciting news. However, it is too premature to be excited. And I would love to take any other questions that you have. Thanks, Dr. Biswas.
Thank you, Dr. Soren. So that was a great insight. So everybody's understanding. So now we go back to the. So Dr. Soren, please unshare, no?
Yeah.
Please unshare. Yeah.
Yeah.
So we did understand that is a phase 2 small study, single institution, so accelerated approval. So there were news, first time in history, cancer vanishes for every patient in the drug trial. So in the New York Times, so you can see those, the patients on digital rectal examination, on a colonoscopy, on a PET, on an MRI. So that shows that the disease is not there. So Dr. Lewis, who is the primary investigator, principal investigator, told that this is the first time this has happened in the history of cancer. And you can see after that, so there are n number of stories that has come up. For the trial, patients took dostarlimab every 3 weeks for 6 months. They were all in a similar stage of their cancer. It was locally advanced. So we are talking about a locally advanced. So this was stage 2 and stage 3. So mind it, no stage 4, because stage 4 already proven. And this is Andrea Serek, who is the first author of this NEGM. So she says mismatch repair deficient tumors are sensitive to checkpoint inhibitors. and Dr. already MB has already alluded to that. She added, thus our hypothesis was that PD-1 blockade with dostarlimab could replace chemotherapy and potentially eliminate the need of radiation and surgery. So they showed that these are the patient populations, so probably in future they can skip chemoradiotherapy and surgery. And if you look at the publication, so 14 patients, median age of 54, 67% are women, 61% are white, with all of these patients who are mismatch repair deficient in stage 2 and stage 3. So these patients, after evaluation, have gone into a complete remission. There is no evidence of disease, and hence these patients have not been offered any of the standard therapy like chemoradiation and surgery. So the key findings we have already discussed. So looking ahead, so given the remarkable response of 100% treatment with PD-1 blockade, dostarlimab may replace the current standard of care for locally advanced rectal cancers. So we are continuing this study in this patient population and planning an expansion study. So we are also studying the microenvironment in the samples collected in this trial to determine why we see such a robust responses. Additionally, we are studying neoadjuvant PD-1. So looking at these two other cancers like gastric, pancreas, and bladder cancers. Just so Dr. Soren, so hopefully this phase 3 trial will be planned.
Sorry, say that again, Dr. Biswas. Phase 3 will be?
So with these results, so I think so that the phase 3 in the larger cohort has to be tried.
Of course, yes. The regulators make it mandatory that if you do a trial at phase 1 or phase 2 and you have shown that there is benefit, which is a surrogate marker, or you are seeing vanishing of the tumor or even a decrease in the tumor size, then you have to continue and see if there is any recurrence of the tumor. In this case, the period of study, if you see, is around 12 months. So the study will continue, and the sponsor has to submit the data to the regulators.
Right. So first time in the history, drug called dostarlimab, potential cure, more about the clinical trial, what report says, and so although about an Indian origin patient. So Dr. MB, so everywhere you see, so there out of these 18 patients, one of them was Indian origin. So is there an ethnical difference?
So yes, sir, I think, yes, there should be a ethnical difference. So we need to understand why a GI cancer with MSI high, that to a localized disease, has complete response, not a metastatic disease. So a GI cancer is completely different when compared to a lung cancer or a breast cancer. We have seen lung cancer, we have used neoadjuvant immunotherapy, and the response rates are around 40%. You don't see a complete response there. And in a metastatic GI, for example, pembrolizumab, or even the same drug, what we are talking about, in the metastatic disease, the complete response around 10% or 15% and not more than that.
Yes,
but
less than 20%, less than 20%, yeah.
Less than 20% complete responses. But in a localized disease in MSI high, we are seeing 100% complete responses. The reason for this is, number one, GI is a site where there are already a mucosa-associated lymphoid tissue already existing. So there is an immune cell already present in situ, no need of any trafficking from elsewhere, number one. Number two, the microbiota inside the GI, they also enhance an immunity killing. Therefore, GI cancers are exquisitely immune sensitive, especially MSI high.
Yes,
because of these
so Dr. Purvesh sir has always been a very fascinating for a micro environment. Yeah.
So this because the rectum has higher microbiota plus mucosal lymphoid tissue plus an MSI high. Definitely you have got complete response, and I am not surprised if I use other IOs in the same scenario. I would expect a similar response.
Great.
So
hopefully that should come.
So my whole thought is, until we have this drug available in our country, why not we use the available low dose therapies? You know, the paper is already out.
So that
exciting
would
to
be,
use
so
low dose
Chandrakant, so that will be
immunotherapy.
difficult unless and until, so the legal binding, the company's PAP
I
program.
agree.
So,
Yes, I agree, sir. But definitely, I don't see a reason why when Pembro and when dostarlimab have similar sort of response in a metastatic setting and in a localized setting with this milieu, I think even
so
those molecules
that is
also
what,
will
that
kill.
is a
So
whole
this
about the
subset
clinical
of
trial. So,
yes.
yeah,
So,
Dr. Biren.
definitely,
Yeah. So Dr. Biren, so do you find any ethnical difference like a MSI? Because we understand there is a difference, the BRCA, BRCA or BRCA-ness. So is there ethnical variance for an MSI?
See, for any genetic changes, for any genetic or epigenetic changes, there will be ethnicity changes, population differences, environmental changes, and racial differences. That is obviously there, and also the age factor. If the mutations load is at early age, it will be aggressive tumors. If it is the late age, there will be not that aggressive tumors. So therefore, ethnicity changes, racial changes will be there. But nevertheless, I am very hopeful that this is a prima facie evidence of the first targeted therapy, cleaning up a tumor, cleaning up a complete tumor in 18 patients.
Absolutely, absolutely. The whole world is amazed to see the response.
The most important aspect. See, we can argue that it is not metastatic setting, it is not the sample size is low. All those we argue, but the drive home point is there is a genetic background of mismatch repair, MSI high, and they are early tumors, and they have immune surveillance deficiency, and PD-1 is inhibited, and there is the complete remission. This is the kind of take-home message we all should be excited upon, and other tumors will follow. Other therapies are there to follow. This is very encouraging, and there will be also, this is also a stepping stone for the next frontier, that is personalized tumor targeted vaccination therapy.
Right. So these are all the KOLs that has been speaking around in the media, on the newspaper. So Dr. Kumar Prabhas, the present HOD of Medical Oncology at Tata Memorial. So Times of India 2 days back. So way too early to say world has found easy cure for cancer. So what happens to a common man? So who used to think that cancer is a death sentence, so suddenly think that the cancer cure has come. The patients who are colorectal patients, so they think that, so this is the probably the Amrit they have. But the oncologists are divided. Somebody who is a researcher like Dr. Soren, so they will wait. There are clinicians, there are many who probably jump into. This is Dr. Pramesh, so director at Tata Memorial, so heads the thoracic department. So he also encourages, but again, with a caution that the whole world is looking at. So these were some statements by Dr. Purvish Parikh. So why is everyone jumping? So he actually promotes research. So that's why, so he said, so why is everyone jumping to criticize this study? So why so much of negative in the oncology population? Of course, it is meant for a small fraction of patients. That is the main objective of precision medicine and personalized oncology. Clamoring for large randomized trial is ridiculous. 12 out of 12 makes it unethical not to offer this to eligible patients. Cost is a definite factor, but has always been so. CAR T-cell therapy for a Novartis costs something around 4 crores. Yet at least 3 academic government centers in the country, we are talking about India, are doing the trials already from the south and from Tata Memorial. So cost is a bogey that people raise when they have no other point. So government of Rajasthan has already said that all cancer therapy will be provided free to all. So Dr. Soren, a crisp comment on this before we can conclude.
Sorry, Dr. Biswas, comment on the cost factor.
No, cost no. So overall, this is a Dr. Purvi's statement. So he says that clamoring for a large randomized trial is ridiculous. 12 out of 12 makes it unethical not to offer this to eligible patients.
Absolutely. So here are my points for this. The sample size that has been taken is small, I agree. However, we also have to look at the following. I would consider that again in a similar lines as Dr. Purvish has mentioned. The segment of patients are not just colorectal patients, they are a particular type of colorectal patients. Apart from the pathological type, you have to also look at, especially this is for clinicians who have not been a part of clinical trials. Each of these clinical trials has a lot of exclusion criteria, which has not been checked. For example, if the patient has diabetes, it will be an exclusion because we do not know whether this drug is going to react, interact, or cross-react with anti-diabetic drugs or even insulin. That is one. The other is when you talk about the small sample size, the FDA has made it, the regulatory body has made it very clear, even if the sample size is low, you have to extend that study beyond what has been defined in the protocol. So that prolongation of the study will give you long-term benefits because we are looking at a chronic study. It's not an infection that it's gone. We are looking at long-term benefits of this particular drug or similar drugs. So a long duration observation and follow-up of the patients is more critical in such conditions, especially when they get an accelerated approval. Now, the other point about cost factor, there are many, as Dr. Purvish has very rightly mentioned about CAR therapy. If India and Indian clinicians get into more global clinical research projects, they will get access. That means the patients will get access to such expensive drugs, which are going to be phenomenal in terms of their efficacy and very low toxicity or excellent safety profile. And if we can get it, for example, Dr. Biswas, you must be aware, we were part of the selinexor trial that happened in India for relapsed multiple myeloma and DLBCL. Now that drug has been approved in the US, and the cost for 4 tablets in a month is around $21,000. I'm pretty confident that it will also come to India because there is a cost factor that we looked into in India by the global pharma companies, because here we are dealing with absolute numbers. A 1% disease incidence in India runs into thousands and lakhs. So the global sponsor will definitely look at India as a potential area for not just clinical research, but just for marketing the product.
Right. So thank you. So let's come to let's wind up. So we have talked about the dostarlimab FDA approved. So Dr. MB has said, Dr. Swaran has said. So 17th August 2021 for other cancers, solid tumors. So we have understood the mechanism of action. So it is a PD-1 inhibitors like Pembro and nivolumab. So the company we know by this time. So to the end, the topic. So this is something called Gartner hype cycle. So one axis is visibility, the other axis is time. So once there is a technology trigger like this in ASCO news, there is a peak of inflated expectations. And you can suddenly see, so we have seen drugs from Eli Lilly like the oratumab for a sarcoma. And suddenly the phase 2 was so good, the phase 3 we see, so there was hardly, so the drug had to be withdrawn. So trough of disillusionment, then slope of enlightenment, and plateau of productivity. So Dr. MB, so any comment on this? So because in COVID times, there are so many approvals and there has been so many withdrawals also, durvalumab, particularly from many indications.
Very valid point, sir. Excellent curve to say everything about the drug. So yes, the excitement is required, because we should not discourage any new upcoming drugs, but we should be cautious and we should await for long-term data, and we should see for phase 3 data before we replicate in clinical practice. Very well represented. So we need to have a longer follow-up for this. We need to see how many fail locally, but if it doesn't fail, and if this has, so for example, in a Nivo-EP trial, those patients who had complete response, 80% of them remained so for up to 5 years. So if this promises to have a complete response for a long time, it is really practice changing. And before doing a CT-RT, we must always do a MSI in all patients we
Right.
can afford.
So this morning, so MB's partner, colleague, Vivek posted in our group from R.K. Lakshman in 1962. Of course, you weren't spreading rumors. The charge is you were spreading facts. So that's what is happening. So our understanding of colorectal cancer, and that too metastatic colorectal, now we are talking about the locally advanced rectal cancer as a disease is continually evolving. So we knew nothing, and today, so there are so many biomarkers that have come place. So thank you, ladies and gentlemen, for this 1 hour plus now. And I especially thank Dr. Biren, Dr. Subhashish, Dr. Agasti, Dr. Soren Das, MB Chandrakant, Sanjeev, Dr. Sanjeev, and Dr. Dilip Kaur. So the COVID is back. So probably restoring the balance for cancer care in the COVID-19 era. So nothing has stopped the physician, the researchers for doing a good research even in the COVID. Neither the oncologist or a treating physician or surgeon has stopped their work in the COVID time. So that's the beauty of science, that's the beauty of oncology. So thank you, friends. So any closing comments, or otherwise I hand over it to Fatima.
Thank you, sir. Thank you.
If there are any questions, you can put it up in the chat box. In the meanwhile, I would like to give the vote of thanks. So on behalf of the International Association of Oncology, I heartily like to thank all the delegates and students who have joined us today. Thank you all for participating in this wonderful webinar, and I am happy to inform you all that our annual series, 4th Indo-Oncology 2022, is scheduled for 11th, 12th, and 13th of November 2022. For more information, you can visit our website, indooncologysummit.com. Also, please stay tuned with us for more updates regarding the IAO webinar and conferences. You can download your e-certificate on our IAO dashboard as well.
So I find no questions in the chat box, so we can close. So
all right, so thank you, Dr. Vishwa. So thank you to all the wonderful doctors who have participated in this. So on that note, we will be ending the webinar. Thank you to all for your time and your energy. This is Yueria, your host, signing off. Good evening, everyone, and have a wonderful.
Thank you.
Thank you. Namaskar.
Thank you.
Thank you, Don.
Thank you.